Thank you for joining us for the third annual Global Summit, Global Kidney Innovations, Expanding Patient Choices and Outcomes, a collaborative partnership event presented by the American Association of Kidney Patients and the George Washington University School of Medicine and Health Sciences. My name is Ed Hickey. I am Vice President of AAKP and Chair of its Veterans Health Initiative. I'm a former Marine and chronic kidney disease patient whose treatment and prognosis are going very well. Being part of AAKP allows me to help deliver the best care possible to kidney patients. I, as chair of the Veterans Health Initiative, interact with the VA and make sure that veterans are getting the best treatment possible. We work with the veteran service organizations and also with the regulators who pass legislation and regulations that impact kidney patients. Often we're the only patient voice at the table when these regulations are being promulgated. And it's critical that our voices are heard as kidney patients, because it's not always been that way. Kidney patient voices have not always been considered. And the impact that we have by focusing people on the ultimate deliverable here, which is the best care for kidney patients, is something that AAKP is able to bring to the table every time and every place we go. Today, I'm pleased to introduce the following speakers who are good friends and allies of AAKP and fellow kidney patients for our session on International Kidney Innovations Consortium, Patients-Driven Transformations in Global Care and Care Delivery. Raymond Vanholder, President of the European Kidney Alliance, Daniel Gallego, President of the European Kidney Patients Federation, who is also a former transplant patient and currently undergoing home hemodialysis. Mr. Vanholder, take it away.
Good morning or good afternoon, ladies and gentlemen. Thank you very much for the kind invitation to participate in this very important event. And start with the topic that I have been allotted is to talk about the need for patient-driven innovations in kidney care. And this talk is also on behalf of the European Kidney Health Alliance, or abbreviated ECHA, which is a Brussels-based NGO. On this slide, I illustrate you what is ECHA about. We aim at defending the case of patients with kidney disease, and this, first of all, at the level of the European Union, and from there, top to bottom at the national level. And we represent not only the physicians and the nurses, but also the foundations and above all the patients whose contribution is very well appreciated and allows us to also use a bottom-up approach because they can make clear to policymakers and administrators what their life is about and what is really burdening them. And if we then look on the right side, you see our members on top, our main members or full members that are the main European organizations dealing with foundations, nurses, doctors, and patients. That includes ERA-EDTA, but also European Kidney Patient Federation, but also the International Society of Nephrology that became our member very recently. And below you see also that we are as well representing 14 national societies that are involved with kidney disease. Many of the thoughts that I'm discussing today have been formulated more extensively in this recently published paper in Clinical Kidney Journal, which is also quite easy to access for you because it is an open access journal. So just Googling my name and Unbearable or Lightness or Clinical Kidney Journal will get you the paper that has been written in a language that is comprehensible to everybody, because it's also intended to be used towards politicians and administration. Now, first of all, what I'm wanting to talk to you is patient-centered outcomes. And here on this slide, you see the back of a patient full of scratches. who suffers from itching. Patient-centered outcomes have received not enough attention for a long time. Now it is improving, but still there is, to my opinion, a lot of ways to go to further improve things. And most importantly, these outcomes may not have an impact on survival or on hospitalization, but they are bothering the patients very much and make their life quite uncomfortable. And itching is a typical example because doctors are not aware of it, because they simply do not ask of it, and because of that also they do not know or they do not realize that it exists and that they could do or should do something against it. Now, in the paper in Clinical Kidney Journal, there is a whole list of bothersome things for patients. That's not only about symptoms, but also about their social life and their education, which I'm not going to discuss into detail. But here you see a pop-up of the main symptoms that are present. They are not only related to itching, but also to a lot of neurological and mental changes, together with pain and fatigue, and also loss of appetite, which then leads to malnutrition and to frailty. And that may have or give an incentive to make PROM-driven, patient-centered outcomes-driven reimbursement of kidney replacement therapy, although this issue necessitates further study and well-to-do planning, just to avoid cherry-picking from kidney replacement centers and selection of patients. This is an inquiry with patients to ask for their appreciation on the impact on their quality of life of peritoneal dialysis towards hemodialysis. By extension, we must say that PD means also home hemodialysis, whereas what is written here as hemodialysis is in fact in-center hemodialysis. And as you can see from the slide in the yellow field, any figure that is above 1 is favoring peritoneal dialysis, and it is clear that all over the record, peritoneal dialysis and home dialysis at large is doing better than in-center hemodialysis. Now, together with the fact that PD is also less costly than in-center hemodialysis, one would expect that PD and home treatment is very popular among dialysis centers in Europe, but that is not the case. As you can see from the blue block, the sum of peritoneal dialysis and home hemodialysis is only 12%, whereas close to 90% are still treated by in-center hemodialysis. If we now are comparing individual European countries, then you see that there are huge differences in uptake of peritoneal dialysis, with Scandinavian countries scoring very high. That's below on the bottom of the slide, whereas on top there are a number of countries that are really not doing very well. And the logical conclusion should be that those countries not doing very well could be taught how to proceed from the countries that are doing very well. But this necessitates, of course, a platform that gives the opportunity to exchange experiences and a certain openness of the countries that are lagging behind and a willingness to modify their system. So we need to work also on possibilities to enable this exchange. If we now switch to transplantation, which again is an option with better quality of life, and now by far less expensive for community, and on top of that, also with a better survival, we see the same picture. On top, there are countries that are doing very well in Europe, and below there are countries with almost no transplantation. So again, those countries not doing well could be learning from those doing better. Now, the red part of the bars is on living donation, the blue part on deceased donation. So it is also clear that in living donation, there is a huge difference among countries, and that even countries that are doing very well in transplantation have a very low number of living donation, whereas on the other hand, and that's then more in the lower end of the spectrum, there are a number of countries that are working almost 100% with living donation. So in both cases, there is a way for improvement and increasing the number of transplantations. Now, in Europe, the European Union has launched in 2009 till 2015 action plan for promoting organ donation and transplantation. That is what is illustrated by the black bar and the arrow. The vertical bars are illustrating the number of transplantations throughout Europe for 1 year from 2010 up till 2019. So you can see that this number is steadily increasing. But if we now look on the right side of the table, that is the increase per year of transplantation rate versus the previous year, it is clear that the rise stopped more or less in 2017, that is 2 years after the action plan, and then tends to stagnate to virtually no rise during 2019. And that is the reason why we as ECHA think that a new action plan on transplantation in Europe is needed. We formulated with ECHA and a number of other stakeholder organizations a joint statement that actually was ordered by the European to us with recommendations around 12 key topics on how to improve transplantation rate throughout Europe. And that plan and joint statement was further extended in this roadmap paper that was published very recently online in Nature Reviews Nephrology, Organ Donation and Transplantation, a multi-stakeholder call to action, where even more extended ideas about how to improve transplantation are formulated. And if we pick out the most important key points and those that were ranked on top, then you see that it is to a large extent about donation. First of all, organizing donation, then optimizing living donation, and also expanded donation. But this is also about education and about equity. Now, coming back to education, one of the big problems is the lack of health literacy of kidney disease patients. And that is a problem that is not specific for kidney disease, but for all chronic diseases. The blue circle is showing the health literacy in this meta-analysis on top of CKD patients not on kidney replacement therapy, and in the middle for patients on dialysis, and then below it's about transplantation. So which health illiteracy is around 25-30% for CKD patients and for hemodialysis and dialysis patients. It's a little bit better for transplantation, but that means that many people are not really very much aware of how to deal with their disorder. And that is also shown on this slide. This is an inquiry that we run in Europe with ECHA in 2017, asking the people, the patients on kidney replacement therapy about their satisfaction on different modalities and the education on these different modalities. This is the question on their satisfaction about peritoneal dialysis education before they started with dialysis. The red part of the bar is illustrating dissatisfaction. So it is clear that there is a large difference among European countries, and also average about 35 to 40% of people throughout Europe are dissatisfied with the education that they got on peritoneal dialysis. And actually for home hemodialysis, the results were even worse. And they were slightly better for transplantation, but still not very satisfactory. And what is also interesting is that countries like Greece, that is the third bar from the right, that are not promoting very much peritoneal dialysis on their side also do not inform very well about peritoneal dialysis. So we are faced with this sort of vicious circle whereby communities where a certain treatment is not very well adopted also do not give very much influence and not much education about this modality. So what do we need? Well, first of all, studies, in-depth studies, international studies on the factors that cause these differences in uptake that should not only be directed at patients, but in the first place directed at patients, but also look at doctors and also look at governments and administrations. And then we need also that the research is turned into favoring the patient. And there are, to our opinion, four major cornerstones. The first one is prevention. Of course, the best way to avoid trouble with disease is just to avoid the disease itself. But then there is also personalized medicine, and it's related for the patients essentially to the fact whether they get proper treatment that is best suited for them. There is improving quality of life. I think I do not need to explain what this does to the patient. And finally, regenerative medicine, which will make possible the improvement of treatment, but also the spread of treatment if stem cell biology is improving up to a moment that we can perform transplantation with stem cells. That will just increase the transplantation rate, decrease the failure rate of transplants, and further improve quality of life. Just a specific focus on one initiative that is running in many countries. Also in the United States, there are things similar to develop dialysis treatment, compact dialysis treatment that is either portable or wearable, that makes the treatment more flexible, allows people to travel and to go around, and also is easier to apply. In this case, it's a collaborative effort between the Dutch Kidney Foundation, a Swiss company, the Biotech, and Singapore expertise with sorbents, but something similar is happening in the States as well. And all this must give the possibility to improve the burden of kidney disease, improve the fate of patients, but also improve the enormous societal burden. Here on this slide, we are illustrating the yearly European cost of kidney replacement, of kidney disease at large. That is illustrated in the right side of the slide. So that is CKD in blue and green, but also transplantation in red and dialysis in yellow. And compared to cancer in blue, diabetes in purple, and cardiovascular disease in yellow. So you see, first of all, that kidney disease is most expensive of all, but the most disturbing thing is that kidney disease receives much less attention than the other three, than cancer, diabetes, and cardiovascular disease, regarding support for research, innovation, and actually awareness of the population at large. There is also an ecological burden that not should be forgotten. Dialysis is consuming enormous amounts of water and plastic, so also this problem needs to be solved. And that's the reason why with ECA we decided to join this splendid initiative of yours, the Decade of the Kidney, and that we are now developing a 10-year plan to increase awareness and response to kidney disease at the European level, which will be something like climbing a mountain. We are only at base camp right now, but we are intending to improve and to proceed and to improve things for patients as much as possible in the years to come. And we got already a very positive response to start with from the European Parliament and also from the European Commissioner for Health, Stella Kyriakides. And that brings me to the two last second slides. First of all, what we intend is to get the same activity in Europe as was seen over the last 30 years for cancer, because we think that kidney disease will become the cancer of the 21st century. And therefore, what we want is more awareness, more innovative research, more attention for patient-oriented outcomes, more and better information, more home dialysis, more transplantation, more flexible therapies, and better outcomes, and all this in favor of the patients. I thank you for your attention.
Thank you, Raymond, for those excellent remarks. Mr. Gallego, it's your turn.
Hi, everybody from Europe, and my pleasure and honor to be here. And many thanks for the kind invitation of AAKP to participate in this third Global Annual Summit. My talk is about the patient-driven transformation in global care and care delivery. As you know, what really matters to the patient is the humanistic burden of the kidney disease. The humanistic burden of the kidney disease is the daily life activities, the health related with quality of life, the social participation, and of course, caregiver health related with quality of life. As you can see here, the patient's mantras that we have heard a long time ago, the patient-centered care, patient at the heart, shared decision-making, drivers of innovation, in the DNA of the clinical trial, the humanization of healthcare. But these mantras are coming from the healthcare professionals, and it's not the reality that really matters to the kidney patients. You can see here the kidney patient journey, and you, especially if you are young, you will be candidate to one or more transplant, but only 30% of people with kidney disease, kidney failure in any stage of kidney disease is candidate to the transplant. So we need a research and innovation to prevent the graft rejection, the chronic graft rejection, because as you know, the average duration of the kidney transplant is only 12, 15 years. So dialysis is not replacing the kidneys, only a small fraction, and you will be on this roller coaster and during the transplant and come back to dialysis and so on. And the dialysis is unable to replicate the kidney functions. Nowadays, the dialysis therapies provides only survival, and it's not real wearable or not real portable options. We need a tiny kidney replacement therapies, and because the dialysis therapies are far from adequate and not easy to move, and we need too many supplies, too many storage, and takes weeks of planification to go abroad or to travel abroad. And you know, this don't promote a real mobility, and this lack of innovation is killing us. So we are claiming, and we are to reivindicate that we need an innovation and real options, new options to conciliate the work and daily life activities and social participation. So we need, of course, this innovation with novel devices that allows to the connection, maybe 24/7 sessions within dialysis units, not only in the facilities, but also in your body. And maybe we can customize new sessions, new dialysis sessions, or new kidney replacement therapies, customized and unique for every kidney patient. And we are still waiting for the kidney regeneration. So this is another line. We would like to invest more research in the kidney regeneration, the kidney cure. And in the meantime, we need better water purification systems, and of course, to try to achieve the dialysate regeneration to improve all the supplies, all the storage in the home therapies, and in particular in the facilities. And we need to more innovation and real novel devices in a real-time patient monitoring that facilitates the quality of life and facilitates to live with the kidney disease. As you can see, the complacency is not an option, it's not an ethical option, and we are claiming for better and new therapies. What we have now, these home therapies, we are promoting that the home therapies are the safest treatment during the COVID-19 pandemic, and we strongly believe that the chronicity should be managed at home whenever is possible, because for home and family is a therapeutic element itself, and promotes this concept that we really love, that is co-responsibility, to promote self-caring and to promote the autonomy to have options, to have choices, and enables a real shared decision making. Home therapies is a real kidney replacement therapy adapted, a real convenient dialysis with less diet and fluid restrictions. That is what really matters to the patients, because we are living in a society that celebrates everything around the table by eating and drinking, and is crucial. The nutrition, and with less diet and fluid restriction, you are more free to have a social participation. And of course, I would like to have the opportunity to claim innovation and development and investigation in vascular access, because we have the same vascular access during the last 50 years with a high mortality and high comorbidity, and we are claiming for vascular access permanent, painless, and without infections, because it's what really matters to the patients. These needles cause heart and a real suffering to the kidney patients, and it is not easy to learn to live with a vascular access, permanent vascular access in your body. And we need to address the unmet needs regarding chronic kidney disease, because it's all related with the quality of life, like pruritus and itching, the insomnia, sleeplessness, anemia and fatigue, because it's very a heart disability, chronic pain, sexuality, and mental health. These unmet needs are always present, related and associated with chronic kidney disease, and we need to do an approach and really address these needs. And as patients, we would like to have a one step beyond, because sit at the table with all of the stakeholders to promote this innovation, and to have a voice with an opinion to design all the health policies, the health strategic committees, and develop all the clinical guidelines, to have a co-production with all the physicians, all the stakeholders together, develops this kind of thing, this kind of co-production, and the care process design, the evaluation of the results. I think it's extremely important to incorporate one kidney patient in all these committees and all the strategies, all the approaches. And driving the transformation, I think we need to share experiences to exchange the best practice in chronic kidney disease. Everything has worked for kidney patients around the world. I think we need best coordination between countries and institutions and international consortium and global summits like this to address these unmet needs and home therapies and the promotion of home therapies. I think they are under use. And we need to raise awareness to the family and caregivers to have all these options available. Of course, to develop telemedicine and full consultation, but we need to be careful to don't leave anybody behind. We have elderly people with disabilities. Not everybody has a smartphone, so we need to be careful with the telemedicine and digital tools, but the telemedicine and assistance, I think the virtual support will be the future, always with balance with a presence and the face-to-face meetings. And then the digital transformation, we need to connect all the primary care, the prevention and early detection with the nephrology services and the big data, this digital registry. We need a real time to know where everybody is in the system, where the kidney patients are in emergency, in primary care, in the first level or in the last level of the disease. So we need a real data in real time. And of course, we have to learn lessons from the pandemic because we get used to the hospital too much, and we need to consider maybe the pharmacy, a home delivery, and community pharmacy. Maybe one hospital medicines could be delivered at home, and kidney patients always add value to every initiative. I think we need to consider to include kidney patients always as the reported experience as crucial, as we can become kidney patients as decision makers. And finally, for take kidney home messages, don't forget that what really matters to the patient is the human and caring touch. I think this is truly important, communication between professionals and patients. This is innovation, these initiatives should be done with patients, not without patients. And we need to promote new therapies, novel devices, innovation, with telemedicine and real data. Be careful with elderly people and people with disabilities and all the resources that we need for digital tools. But as patient organizations, as physicians, as industry, we are true seekers. We need to know what really matters to the people, to the patients, not only from the kidney clinical aspect, not only for the economical aspect, but also for the humanistic aspects and humanistic burden of the disease. Include, please, the reported experience as crucial, and include a kidney patient from the design of the clinical trials and research, and promote, of course, always home therapies in the meantime until we achieve a kidney cure or a kidney regeneration. Kidney disease is like a riding a bicycle. To keep your balance, you must keep moving. We need to keep moving forward in the kidney disease innovation, in the kidney disease therapies, and I think we are in the best scenario, and to move forward now. And many thanks for your invitation. Of course, this is a global annual summit, and we keep in touch, and we are trying to collaborate always with AAKP, with other organizations to find the best way to address the global issue that is kidney disease. Thank you very much.
We appreciate Mr. Vanholder, Mr. Gallego, for taking the time to share their insights and expertise on how patients, as consumers of healthcare, can drive change in status quo kidney care worldwide. Thank you all.